This evening, as you can see in front of you, we will be talking about infective endocarditis for the first half an hour, a presentation by Dr. Jeff Sarton. And then for the remaining half hour, I will talk 15 minutes on pharmacology review, followed by 15 minutes of a clinical review of the topics listed in front of you here.
Well, I want to talk to you about endocarditis. It's a very important topic, one that's near and dear to my heart. It's a fairly common thing, which again, if you're in a general kind of a practice, you're going to see, once or twice a year. How do you diagnose this? Well, when you have all of the pieces of the puzzle, it's really very straightforward, but unfortunately, we don't always have all the pieces. Generally, you will have positive blood cultures. So you want to draw them when someone is off antibiotics. 2 sets are usually sufficient, but if someone has had antibiotics recently, you might want to get a 3rd set. Special organisms can't be cultured out, and so we have to do serology. So these are things like Q fever, chlamydia, cat scratch disease, etc., and an echocardiogram. We already talked about the echocardiogram, sensitivity and specificity. This is the vegetation on the echo. Generally, we're going to want to get a transesophageal echo. Now, there might be cases where it wouldn't really change the treatment. Maybe you have a patient who's extremely debilitated. There are cases where you might not need to get that echo, but in most cases, the transesophageal offers a much better look at the valves, especially the aortic, and you're going to want to get that as part of your workup. Causative organisms, well, if we'd given this talk 40 years ago, probably we would have said strep viridans is far and away the most common cause. What we've seen over the last few years is that Staph aureus is coming to play a more prominent role, and also Staph coagulase negative and Enterococcus. And the reason for these latter organisms is more nosocomial infections, indwelling devices, etc.
Next, we're going to talk about 2 medication reviews, the first one being vancomycin. Vancomycin is a bactericidal antibiotic, as Dr. Sarton had mentioned earlier. Specifically, it is in a class known as the glycopeptides. This is a medicine used for gram-positive infections, and I'll talk a little bit more about this in a moment. In the early 50s, it was discovered that a soil bacterium known as actinobacteria actually makes vancomycin naturally to fight off other bacteria. Endocarditis, as Dr. Sarton had mentioned earlier, there are different subtypes of this, if it's the native valve versus a prosthetic valve, but generally speaking, about 1,000 milligrams or 1 gram Q12 hours for 4 to 6 weeks. That may be combined with gentamicin for 4 to 6 weeks as well. For patients who have the methicillin-resistant Staph aureus, then we're going to use a little bit of a higher dosing, 15 to 20 milligrams per kilo divided out with not only gentamicin for the first couple weeks, but also mixed with rifampin. And we do see this from time to time in our hospital setting where I work. Osteomyelitis, 15 to 20 milligrams per kilo per dose divided out, and surgical prophylaxis, as mentioned before, about 1 gram before surgery, 30 to 60 minutes beforehand. Vancomycin is not a medicine that if you're going to keep somebody on for any extended period of time, generally speaking over 3 days, you do need to do some monitoring of their levels. Years ago, they would check not only the trough levels but the peak levels. Nowadays, we're really only checking the trough levels, which is measured right before the next dose that's given. And the trough level should be in the range of somewhere 10 to 15 milligrams per deciliter. Once these levels become very high, over 60, over 80, then it becomes severely toxic to the body. Mentioned left-sided heart valves are more susceptible to endocarditis than right-sided valves, but any valve could become infectious with the vegetation. As seen here, the left ventricle empties its contents across the aortic valve to get it into the ascending aorta. The top orange line that you see is the top portion of the aortic valve, which is known as the sinotubular junction, where the green line is basically the fibrous ring or the basal attachment of the leaflets here. Here are the 4 stains that are used in the Gram stain. The first one is the purple dye of crystal violet, where basically all the organisms are stained purple. Then the application of a second mordant layer, the iodine layer, helps seal it in. There is a third step where alcohol is used to wash away the crystal violet that is not being stuck to the gram-positives. Basically, the gram-negative organisms, as you can see here, are not picking up the stain because it's washed away. And then the fourth stain is the safranin stain. So this safranin stain is a counter stain that will then be picked up by the gram-negative organisms that we see as pink or purple as listed down here below. Once the organisms are either classified as either gram-positive or gram-negative, then we look at their shapes. These Roth spots were actually discovered in about 1872, but Dr. Roth was not given credit for it until about 10 years later. And these are white-centered hemorrhages. Basically, they're flame hemorrhages around these areas in the center that are clear. And of interest, I learned that these can actually appear and disappear pretty quick, meaning within 20 minutes or so they could show up and also kind of dissipate within another 10 or 15 minutes. So they kind of come and go in certain infections or conditions. Most commonly, we associate these with bacterial endocarditis, but there are other conditions including HIV, diabetes, and ischemic events of patients. They're basically a cotton wool spot surrounded by hemorrhage. Osler's nodes, I do want to point this out because sometimes this can get mixed up with Janeway lesions sometimes, but on the board questions, they do want you to know that Osler nodes are painful, reddish-purple raised lesions on the hands or feet, frequently on the pads of the fingers or toes, and these are from deposits of immune complexes. They're not the septic emboli that we'll talk about with Janeway lesions that we see. This was named after Sir William Osler, who was a Canadian physician. He was one of the big 4 founding professors at Johns Hopkins. Hassic organisms are made up of either Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, or Kingella. Of interest, 2 main things I want to point out. All of these are gram-negative organisms, and all of these are normally found in our oropharyngeal area. They could cause other infections like sinus infections and et cetera. But for this point, we're really going to talk about their importance clinically with native valve endocarditis. The treatment here is important because back in the day, we used to use just penicillin or ampicillin, sometimes in combination with gentamicin or some other aminoglycoside. But because of the increasing beta-lactamase resistance, we are now using either ceftriaxone or ampicillin with sulbactam, known as Unison. With that, I would like to thank all of you for attending our second webinar. Thank you all, and have a good night.